a little bit because this force plate is going to come up until it touches her feet. And this bed is going to go all the way into a tilt table position, a full standing position. So what I'm going to do, actually, if this was my patient, yep, you can help me. I can strap the legs in, strap the chest in. And we talked about, think about what we talked about with strengthening the legs in bed, weight bearing through the legs in bed. Some of the things that we can do here. You can do all those things with this. You can do all the things we typically do. However, this kind of technology, and you can use tilt tables for this. You know, this is coming up to her feet. So look at what's happening in terms of the dorsiflexion in her feet, because what happens with those bedbound patients when they're bedbound for a long time? They lose that ankle dorsiflexion, and then you're trying, you know, I hate mobilizing ankles, you know. You know, okay, let's get that dorsiflexion going. Let's, you know, that's work, especially if they're really stiff or if they're rigid or, you know, they've got some tone issues. But what can I do here? I can bring her up a little bit. Actually, I'm going to bring this a little down, put under her arms. More around her chest. Okay, so she's strapped in, and even your most dependent patient, with this kind of technology, I can do this. How much work am I doing? You know, as much as my husband does, right? Yeah. He's not here, so I can pick up the TV remote. But what am I doing now? Weight bearing, right? We talked about bridging, modified bridging in this area. We've got some weight bearing going through here. We can have her do some hip flexion. Now she's partly anti-gravity. I don't need the straps on. I can loosen the straps up, and then we can use this position to do all the same things that we did in the supine position, but now she's weight bearing. And what do we know about those hemiplegic patients? What is important about weight bearing?
Second year students.
Full contractions, midline orientation, sensory input, midline, equal weight bearing. You know, without this, you know, when we're getting them up, how equal is their weight bearing? It's all or nothing, isn't it? They're either dependent or it's up to the side of the bed and here, and if we dare, you know, once we go to stand them, we all felt that, you know. But this, we can gradually progress it. So day one, she might do this, and we might do those other exercises in this position. Go ahead, pass me those slider sheets. Remember we talked about friction? I'm going to add a component here. Now, if I wanted to do this, I mean, it is really cool. Yeah.
You're right. I don't see that right now. All of a sudden, I like to add it now, but like the possibilities are also.
Absolutely.
That's cool.
And that's what we're hoping is. Let's start thinking, guys. PTs, our strength is thinking outside the box, right? We are creative. We like to do new stuff, and this is. When Jamie and I started playing with this, we're like, oh my gosh, look at the possibilities of what we can do here. So let's go ahead and, ready, 1, 2, 3, under. One, we're going to go underneath here, so bring your arm up underneath this one. Ready, 1, 2, 3, under.
And one of the things to,
It's a good time to work on the bridging too, because then it makes your job easier.
There you go. See if it's can bridge, absolutely.
well, one of the things to think about too is one of the ways. I know we're not talking about injury prevention necessarily. But one of the main reasons why therapists got injured in the literature was of unexpected movements by the patient. It was, oh, I've got them, oh, I don't. It really, that was one of the top 3 reasons why therapists felt they got injured when they gave them a survey, was the unexpected things that happened with more dependent patients. It was they were okay and then they weren't, or the patient decides I'm sitting now, and we've all had those experiences. So
halfway to the bathroom.
Halfway to the bathroom with no one around, no pull cord in sight. So think about that too. As we start to make her a little bit more mobile, is about those unexpected things that not only put us at risk, but can put the patient at risk as well.
And so now we can let her go ahead and just let yourself slide and push back up again. Push, 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 push. Good. Go ahead and slide down, push back up again.
That is so cool.
You know, we can change the range of motion by how tight the strap is. If I want more range of motion, remember we talked about doing that bridging, except that keeping the feet on the bed was a problem right there. The feet kept slipping. Well, guess what? They're up against the force plate now. I can hold in here. Okay, lift your bottom up. Lift, 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 lift. Good. Okay, push yourself back up again. Push, 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 push.
So when we talked about
Good.
facilitation,
Pulling that down again.
when we talk about facilitation, now I can get out we talked about a clinical vibrator using vibration. I don't have to, again, worry that she's going anywhere. I can use sensory inputs. I can tap easier. If I were doing this in standing, I'm so worried about keeping her safe that I can't even put in any sensory input. The other thing, which is really important, is the range of motion and the stretching she's getting through weight bearing for the dorsiflexion. That is huge. And we know in acute care beds, what have you seen? The Prafos, they don't keep your patient in 90 degrees. They don't keep them in neutral. It just isn't as effective. So that's another thing that's great about this. Again, I'm not worried. I can spend more of my time facilitating, less of my time worried about patient safety.
Can I add something? I don't know if this fits in.
No, absolutely.
I mean,
Any
even
idea?
just like you don't have to have special equipment like this, because I know like some clients, they don't have the right shoes. I mean, sometimes you can use aquatic shoes. They got that really good grip.
Yes.
We got to
Good
put your
idea.
surfaces on. And then, like when you're doing your stand procedures and progressions, even if you don't have a nice bed like this, you can work with that. The height of the bed, you can slowly bring them up and then come back down. And when you have like gripping shoes, you can actually have them work with that the same way.
Right.
That's a great idea, Steve.
Yep,
Yeah.
yep, great ideas. And that's it, again, using all the things, friction, no friction. When do we want it? When do we not want it? Thinking about broader concepts rather than specific techniques.
How many people have worked in ICU? Is anybody, okay, so not a lot of us, but, so when you think about when I'm gonna get someone up, and I wanna use a tilt table because I think this is a great idea, what does that entail? If they have a trach, if they have lines, do I wanna spend, I mean, I get one neuromuscular re-ed for 15 minutes of treatment, but it takes me a half an hour to get that patient there. So again, thinking about not just what the patient outcomes, but how much more willing am I now as a therapist I can get 30-minute treatment in 30 minutes, not 15-minute treatment in 45 minutes. And that's huge for acute care because we want more time. I can't see my patients twice a day because I've spent 30 minutes in a 15-minute treatment trying to get them prepared. So that's one of the nice things. If you think, yes, we could do all this on a tilt table, no doubt about it, no doubt about it.
So do you find too that the nursing staff is more willing to even prepare and help break down a patient because they feel safer, because they're more supported than
Sometimes. We don't have this technology yet in our facility. We are getting one of these.
I'm thinking like that. It's like lots of times the nurse is like, hey, you're here, hey, do the transfer, do all
yes,
this stuff, and they don't want to do it.
Yes.
But tell them a little bit about your process that when you introduce some of this.
Huge resistance from it, because it's changed. It's a different way of thinking, and nursing thinking is different from therapy thinking. Nurses are actually more on board with it than therapists are, but the opportunity for therapists is huge. You're absolutely right. And yes, it will make nurses' jobs easier, especially the sliders. Yes, we have sliders under every single patient bed now. We use disposable ones that are like an oversized plastic bag, but they're a little more.
I mean, they're thinking like it would be easier for us because now the nurses feel like they can even set them up or
Yes.
break them down.
Absolutely.
And we don't have to worry about doing all that because they actually want to be able to do that because they're going to use these two to help position.
In our inpatient facility, our inpatient rehab facility, the nurses use it all the time. The therapy staff will write up on the board, we have the Sarah, that, different companies use different terminology and we're not here to sell you that, I need to make that clear. But, use the Sarah, or use the Maxi, or use the slides, or use this. The therapists will upgrade that, and so the nurses are following through on the unit. And we believe that's one of the reasons why our outcomes were better.
Patients are getting out of bed. Patients are getting out of bed
and spending more time per
time.
session in what we want them to be working on. Now, the other thing we talked about with the supine patients was it's all or nothing, right? That we didn't do much with upper extremity, did we? Because they're supine. We do some bridging, some length extremity, stuff like that. But what about reaching in this position? Getting in and doing some scapular stuff, having the sliding. If I was on my own, I'd have a bed rail here. But go ahead and just side bend that trunk side to side. Start doing some stuff. Maybe she can, vestibular patients, that is a much overlooked area of stroke rehab, and patients who've been intubated for a long time and don't move. They don't move their head, they get dizziness, they get, some problems with their vestibular system, balance problems. So we can start stimulating that. We can start, doing some of that, hands, clasp your hands together, we can start doing some reaching, maybe coming forward. Now that's still a lot of work for me. She can't quite get there today in that position, so I note the angle of the bed. You know what, I'm going to bring her up a little bit. because that's too much anti-gravity. We do this with shoulders, don't we? If we can't do anti-gravity, we lay them down and work in this position here, where we start to work the muscles in their most efficient range. Are you really working to stay up there? Is that slider making you slide down? Okay, so you know what, if we don't want that, guess what? We've now added friction to hold her there. So again, we take the slides out if we don't want it. If we want to put them back up again, you know, use this technology to do whatever it is we want to do with the patient. But now, it might be easier for her in this position. Go ahead and come on forward, 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 forward. Maybe we can start getting those abs working. You know, we can start getting some scapular stuff going in. And feel free to jump in, Jamie, if you're thinking.
Yeah, this is all in a position where we can facilitate. If you think about using pin-up patterns and quick stretch, if you think about using resistance, I want you to pull up, pull up, pull up. Good. We use both hands, and pull up. Okay. Now I'm not worried necessarily about all this, and so I can facilitate much better. We can have her reach forward. I can do scapular patterns. There's just all sorts of things that we can do when I'm not worried about having her, worrying about the rest of her position and keeping her safe.
And the whole time she's weight bearing, she's symmetrically weight bearing, she's putting pressure through her feet, she's getting cardiopulmonary, she's getting hemodynamics, you know, exercise. So again, thinking about those real dependent patients, and I just see just endless possibilities.
This is a great way for when we talk about PNF and overflow, how we can exercise stronger muscles to facilitate contractions to weaker muscles. And so again, I can work stronger muscles hoping that flows in, and we can do that because she's weight bearing. So it gives us a lot of different opportunities to encourage that.
The other thing I'm seeing is like, the hardest thing is like when you're especially doing bed positioning, and then you want to document progress. And so you want to do things like the angle, and how hard it is when you're holding the person, and then you're trying to use your goniometer or use a measure and figuring out what's the progress. And here
you can measure angles so you can see what kind of, you know, how far she can go here. Can you slacken this? Does she have that range? You can do that. You can use this as a range of motion tool to improve ankle range of motion. You know,
and you can take your hands off them and you can take an accurate range of motion measurement.
Yes, absolutely.
The other thing you can do, what's really nice about this, is the specifics of the bed, the angle. We use 2 straps today, here and here. The treatment now becomes very reproducible. I mean, we know what it's like to document neuro things in the ICU and trying to make those reproducible for the next therapist that's coming in. Here, the patient was at this angle. They were here and doing sit-ups or doing PNF patterns. Now they're at this angle. That shows progress and documents for the rehab people when they're going from the ICU, getting ready to go to a rehab unit. So those things are all, I mean, just so much easier to document because we've got increments and we've got other things we can use.
Okay. All right. So that's the biggest thing. The other thing that this will do that helps us is go up into a sitting position. And we got to get it back down again. Help me out again. Which one was see, Angela?
7 and 12.
7 and, oh, thank you. Thank you. The other thing that's nice about this is it tells us the weight. All right, so what we can do is if we've got weight bearing precautions, we got a 25% weight bearing through a hip or a 50% weight bearing. We know how much the patient weighs. And then we can put 50% of that through their feet. We know that we're protected in that weight bearing status, so we can work them. And again, we've always thought of weight bearing in terms of laterality, haven't we? You know, if they're fully here and they're, you know, does a patient know 25%? They have no idea what 25% is, you know. And so with this, we can get them doing some marching. We can do some hip abduction, anti-gravity, you know, having them take the weight on that side. If we know it's only 25% of their body weight, you know, does an orthopedic surgeon even know exactly what 25% weight bearing is? You know, it's just a little bit, you know, a little bit of weight. But we can be much more specific with what we do.
Can I say one more thing too about being in the ICU and all the lines? Again, a person could have 12 different lines on them, and what's nice about being in the bed is that now I don't have to worry so much that I'm pulling things out or I'm putting pressure. Versus if I have to transfer someone to a tilt table or if I sit someone up, that's just one extra thing that I need to worry about as a therapist for patient safety.
Okay, so the other thing that we can do with this, let me just